We're not testing the mechanism of injury. We will focus on the signs and symptoms and also the management. So anyone can sustain spinal cord injury, typically the same causes we discussed in head injury, because again, the head sits on top of the atlas bone, which is the top of your spinal cord. Of course, that will same mechanisms that cause the head injury can cause spinal cord injury as well. And just like head injury, because these patients will be bedbound, correct? Especially during the first 24 hours. We'll also discuss two emergencies, spinal shock and neurogenic shock as a complication of the spinal cord injury, and all the consequences that follow anyone who is immobilized, namely pulmonary embolism, DVTs, or skin injuries, pressure injuries, I mean. Everybody knows these terms, right? When we say plegia, what does that mean? Uh, what about paresis? Weakness, okay. So paraplegia, lower part of the body. Now, where it actually begins will depend on which level of the spinal column was injured. So anything below that level of that injury will, of course, have either paresis or plegia. Tetraplegia used to be called quadriplegia. Now we use the term tetra, meaning four, all four extremities. Now, again, we won't discuss the actual mechanism of the injury, meaning I won't test you on because there are many spinal cord syndromes. We will only test one table, which will help us determine what will be the patient's limitations. Okay, we have one table for all of that, outlining from cervical all the way to sacral. And just like with head injuries, there are primary injuries which result directly from the time of injury. And then over the next 24 to 48 hours, the patient will also develop secondary injuries, okay, that result from the swelling, the edema, etc. As I said, we'll look at the table, or maybe it's a chart. No, not this chart. So this is what I meant was we're not testing. These are the different spinal cord syndromes. So we'll skip this part. We'll go ahead instead on the table. This table, okay, table 63-3. But before that, let's not skip this part. Emergency management. So at the scene, remember I said 2 weeks ago that when the patient suffers a head injury, we assume what? There is also spinal cord injury until we can rule out that there's none. Then this also goes both ways. So until you're sure, until we can rule out, we also assume this patient sustained a head injury. So at the scene, of course, we do ABC. After you do your quick assessment that there is no airway problem, for instance, there's no bleeding problem, then you apply a rigid collar to stabilize the neck. Then we move the patient with a backboard. Okay, don't panic as long as the patient is hemodynamically stable, meaning no airway problem. Then we must wait for a backboard. Okay, we need a solid board to put the patient on because we may make the injury worse. Okay. Right. For table 63-3, how this will be asked is, so I'll have a minimum 2 questions. So I'll give you the patient's level of injury. So let's say I'll say the patient sustained an injury at C3 level. And then I'll ask you, which of the following will the patients be expected to perform? Or I can go the opposite. I can say, which of the following cannot be performed by the patient? Okay, so either question. So 2 questions at least. So if I ask you which of these patients can, and I'll give you 4 patients, which patient can use a manual wheelchair? So I'll say patient with a C2 injury, or let's say I'll have C5 or a T1. What will be your answer?
Oh, T1.
Well, there will be 2 answers there. It'll be both T1 and also C5. See here? C5 can, meaning they have upper arm strength. Okay? They can use their shoulder and there's elbow flexion. So they're way capable of using a manual wheelchair. All right. Well, electric only requires fingers. Okay, so you only need hand control for an electric. Actually, no, because Stephen Hawking couldn't use his fingers, but he was able to use his mouth. Yeah, he can move his head. So in Stephen Hawking's case, he can move his wheelchair with his face. Okay, so he can make use the controls. So that wasn't totally accurate. Okay, because we can modify electric wheelchairs now, wherein you don't actually need hand control anymore. But I'll specify on the question, of course. But of course, when you say manual wheelchair, that means you have to move the wheels. Okay. All right. Any question on table 63-3? Okay. We'll move on. Who has ever applied a cervical collar, a rigid collar? You'll be putting these on not only for emergency patients, but post-op patients as well, those with acute or chronic back pains, and they'll have cervical fusion injuries, surgeries. So either anterior or posterior incisions. Simply, I think we have one in the lab. Okay, so simply just remove the Velcro, and these are 2 pieces. Okay, so you will put 1 piece in front, 1 piece in the back, and then just put the Velcro on. Make sure the chin though rests on this area, okay, and not above, because otherwise it won't hold, it won't stabilize the neck. Okay, so the chin should rest on the on this part. Okay, meaning the patient is not exerting any effort lifting their neck, meaning they should be able to rest comfortably on the collar, right? Meaning they're not straining their neck, keeping it straight. Should be able to relax, and then the collar holding pretty much their head up. Okay. Because we have to take it off, and then you have to teach the patient also what to do when they come off, because they have to shower, right? So you take it off, and then they have to change their clothes. Okay, so teach them how to take it off, and also to put it on. Keep in mind that if it's a cervical injury, patient is instructed to look straight ahead whenever the collar is off. Okay, for whatever reason. So just tell them to fix their eyes on something in front of them, and then keep it there. Okay. As I already mentioned, the priority, of course, is ABC. So check for airway, any airway issues, any bleeding issues. Then if none, then put on the rigid collar, cervical collar. For medications, depends really. Not all SCI patients will receive steroids. If they do, it will be methylprednisolone succinate, also called Solu-Medrol, which is different from the steroid we used in head injury. In head injury, we use dexamethasone, correct? To reduce cerebral edema. For reducing spinal cord edema, we use methylprednisolone. But again, not all hospitals use it. And for respirations, remember these patients are at risk for neurogenic shock. And if the injury is high cervical, then we may need respiratory support When I say respiratory support, meaning the patient will be intubated and put on a ventilator. So because here, if we go back to the table, which patient will require full ventilation support? Okay, C1, because there is no diaphragm control. So the patient cannot breathe. Here, C2, C3, they may be okay because the phrenic nerve is not affected here. For immobilization, let's say the patient is now, we have an actual diagnosis about which cervical level the injury is at, then the patient will be placed on skeletal traction. So the most common skeletal traction use is the halo vest. You have a picture here. So this is a form of external fixation device. So just like when you break your arm, for instance, so to immobilize the broken part, in which this case would be the neck, patient would be given an external fixator. So the halo device is drilled into the skull. So you have about 4 to 6 pin sites here. So you have 1 here, 2, then 3. I think there's 4. The pin site is just one aspect of your care. So you simply wash it with, of course, put uh, gauze here, okay, a few pieces of gauze as you wash the area with saline. And the order typically is betadine ointment. So you just use a sterile cotton tip applicator and then apply it on the pin site. Do that once or twice a day, depending on the order. Of course, this is not 24/7. We do remove the halo vest periodically. When we do, there is a wrench behind. Now, this is not an ordinary flat screw or a Phillips screw bolt. There's a special wrench to remove the device. Now, it's removed for, let's say, hygiene purposes and also for emergencies. Let's say this patient suffers cardiac arrest, we need to do CPR, then you need that wrench. So the wrench is always attached behind the vest. Okay, so if you look for the vest, the wrench is always behind the patient. So don't go looking for it in the drawers or anything. It's on the patient. Okay. Obviously for emergency, so we don't have to find it, okay? Um, okay. So how long the patient wears it, it depends. Could be, as mentioned here, could be up to 4 months, or it could also be longer. And you have a chart for full nursing care for patients with halo vest. I won't test this. Again, we're not really involved in deciding whether or not the patient requires surgery. Okay, so these are the 2 acute complications of spinal cord injury. So we finished neurogenic shock already on module 1, just a review. So what are the 3 manifestations of neurogenic shock? Very good. What else? Hypotension and respiratory depression. Okay, so those are the 3. Now what will be the patient's skin condition, by the way, in neurogenic shock? Is it cool and clammy or warm and pink? What type of shock is this? Is this cardiogenic, hypovolemic, distributive, or obstructive? So, okay, so what can we say about, there are 3 distributive shock, right? We have anaphylactic, septic, and neurogenic shock. So what do all those three have in common? Why are they called distributive shock? Yeah, all are the same. But what's the main problem with neurogenic shock or in any of the three distributive shock? Is there vasoconstriction or vasodilation? It's vasodilation here. So I repeat, what's the skin condition here? Warm and pink. Patient will be warm and pink. Again, there's vasodilation here. This is the problem. The reason why the patient's blood pressure dropped was because of the massive vasodilation, because of the loss of sympathetic tone, okay, below the level of injury. Are you okay? You seem to be, oh, okay. So that's the problem with distributive shock. So they have vasodilation. In this particular instance, it's because of the loss of sympathetic tone. So instead of sympathetic, they have parasympathetic. So that's why there is bradycardia here. Spinal shock has nothing to do with shock. I don't really know why they call it shock in the first place. Spinal shock is as described here, sudden depression of reflex activity in spinal cord called areflexia that occurs below the level of injury. What this means is there is loss of sensory motor function. The patient goes paralyzed. However, if it's just spinal shock, it's usually temporary. I repeat, this is usually temporary, meaning the patient recovers. Who has seen Cobra Kai? Season 1. Cobra Kai. Okay, so you remember Miguel? No, I think this is season 2. Season 2. When there was the lovers quarrel, when Miguel and yeah, Lauren's son, what was his name? Okay. When Miguel fell from the second floor and hit his back on the railing of the stairs, he became paralyzed, right? What he sustained, because he regained mobility, right? So what he sustained was actually spinal shock. Now, spinal shock, the thing about spinal shock is it's very unpredictable. We cannot determine when the spinal shock resolves. Some patients, spinal shock resolves within 24 to 48 hours. Some may take months before it resolves. Okay, so who can tell? Nobody can tell. Not even the doctors or surgeons can tell. Okay, so spinal shock will just take its course. When the spinal cord heals spontaneously, then the spinal shock will resolve. Okay, that's the thing about it. We don't know. We can't tell. Spinal shock is temporary. Yeah, but we just don't know when it will resolve. Okay? It will just take its course. Yes. We don't know. We cannot tell. The doctor.
Or they'll ever recover.
Right. Yeah, we don't know if it's spinal shock. But overall, spinal shock is better than tetraplegia or quadriplegia.
You don't know until you get better.
Exactly now, yeah. But that's why it's still important to do rehab, okay, after the injury. And of course, with any immobilized patient, all the complications that go with it. Again, so the ileus, the constipation, pressure injuries, DVTs, PEs, right? Again, I won't repeat neurogenic shock already. VTE, we'll come back to this when we get to PE. I'll come back to this chapter. Because the management is really the same. Okay, so let's go to the collaborative. Now, how do you care for the patient with SCI? Okay, let's start here under nursing interventions, page 2077. First is breathing and airway. So this is your priority, depending again on the level of injury. Go back to table 63-3. So you support breathing if needed. So the higher the cervical injury, then the more likely the patient will require respiratory support, assist with coughing and deep breathing. Improving mobility. You may have to start with passive range of motion and then go into, if the patient recovers, then they'll be able to do active range of motion. This is collaborative, of course, so you'll be working alongside PT, OT. Make sure the patient doesn't, maintaining range of motion will prevent contractures. Joint contractures are permanent. Skin injury, again, these are pressure injuries. Same with skin integrity. The patient can lose, depending again on the level of injury. Patient will lose bowel and bladder sphincter control, yes. We'll get to that, that's a separate section. So the patient here cannot pee. So that means the patient will either have a indwelling catheter indefinitely, or if they go home independently, the usual recommendation is straight catheterization. So it's the lesser evil because straight catheterization doesn't require an indwelling catheter. That means it has a higher chance of avoiding COTI. So no catheter-associated urinary tract infection. And then for patients with a neurogenic bowel, okay, so you can either have a neurogenic bladder, meaning the bladder again does not contract anymore. So which means the patient has to straight cath forever. There can also be a neurogenic bowel, in which case the patient will maintain a cocktail of stool softeners, stimulants, or worst case scenario will be manual disimpaction, just to maintain bowel function. Okay, so I already said that. Okay, so here's the section for the halo vest. So assess the 4 pin sites. Again, daily pin site care is necessary as long as the halo vest is still on. And here are the management for skin discomfort. For instance, if they itch, it tell you what to do, okay, and then especially also what not to do, right? Like putting in powder, for instance, or sticking hangers into the vest, okay? All right, so let's discuss autonomic dysreflexia. Another term is autonomic hyperreflexia. So Brandon Sharp, your patient next week, has this. This does not occur during the acute episode. Okay, so don't confuse the terms here. First, yes, it's an acute life-threatening emergency. However, it does not occur during the acute episode. So that's why the next statement says it occurs only after the spinal shock has resolved. Okay, so therefore, does this happen during the first 24 to 48 hours? No, this will happen after the spinal shock has resolved. So who gets this? Patients with an injury above T6, meaning who are these patients? Quad or paraplegics? All right, so therefore, are spinal cord injury patients at risk for autonomic dysreflexia? Yes, forever. Okay, so they'll have this risk forever. Now, what is the trigger here? What will the patients... Okay, all right, so let's look at the manifestations first. Here are your manifestations. this is quite rare. In fact, in all my practice, I've only seen it happen once. And when it happened, I was more excited than afraid, really, because I've never seen it. And then when I recognized it, and I said, "Oh my God, you're having autonomic dysreflexia." Okay, and I said, "This is incredible. I've never seen this." And then a few seconds later, I realized, "Oh, you're gonna die." Of course, I didn't say that, and then I called the doctor. But these are the ones. What I saw was the patient was complaining of severe headache, which is here. Here's sudden increase in blood pressure, which causes a severe headache. So this was the patient's complaint. Really bad headache. And the heart rate was low. Okay, so typical um, manifestation. So he showed textbook signs and symptoms. He was a paraplegic. The patient was young. He was in his late 30s. So he got paralyzed when he was 18, car accident. And then he's been in a chair since then, but he still parties, plus he's diabetic, so we know him frequently. He always goes into DKA and comes in for hydration, right? So but we know him. We know he's straight cat, so we know what to do. But because he was admitted for DKA, what do we do again for DKA patient? What's the number one thing they receive? Fluids. How much fluids? Massive amounts of fluids, yeah. So we gave him so much fluids, and then remember he goes into AKI also, right? Okay, so he was in AKI, and what happens when does the AKI resolve? We know. Do we know? We know, right? Because they go oliguric first, and then right. So do you know exactly when that happens? No. So neither did we. So we were following his regimen wherein he straight cats twice a day. We were doing it for him. We straight cat him once in the morning and once at bedtime, just like at home. But we didn't realize that he was going into the diuretic phase already. So turns out when he showed the symptoms here, the symptoms he had, the high blood pressure, the severe headache, the goosebumps, diaphoresis below the I mean, above the no, only his upper part of the body was having goosebumps and diaphoresis. So I said, "Oh, bradycardia." And then, "Oh, this is autonomic dysreflexia." And then when I looked at his bladder, it was the size of a basketball. It was not a baseball or a football, like a basketball, really huge bladder. So I know I was gonna get a Foley order, so I went ahead and inserted it, and then someone was calling for an order. Um, First, it was a straight catheter, okay, because I didn't think about a Foley because all I knew was I need to relieve the bladder, right? So I used a straight cath. It comes with a box, right? So the box quickly filled, so I called for, "I need a urinal, please." And then a few seconds later, "I need another urinal." So the total we got was 2,700 ml. I did not know a bladder could hold 2,700 ml, but apparently it could. So what are the triggers? I missed number one though. So the first step I should have done was place the patient in a sitting position. So this will lower the blood pressure. So in order, the interventions in order is number one, what is the first step? Okay, so once you recognize AD, you place the patient in a sitting position. Next, identify the cause. So let's go to the cause. So the triggers are usually the following. Most common is a distended bladder, most common cause, followed by a distended bowel. Any stimulation of the skin. Now, when we say any stimulation, it's literally any stimulation. Tactile, painful, because this is a paraplegic patient, yeah, or a quadriplegic patient. Can they sustain spinal pressure injuries? Yes. Can they sit on their balls without knowing it? Yes, they have no sensation whatsoever. Is that painful? Yes. Can you leave a swab cap on the bed, or a needle cap, or a bottle cap, or a tubing cover on the bed and them laying on it and causing a pressure injury? Yes. So can they be sitting on something hot or cold? Yes, and know nothing about it? Okay, so these are all the triggers, okay? Other triggers are sex. Well, not sex per se, but ejaculation, yeah, orgasm, because basically anything that will stimulate sympathetic stimulation. Okay, do you have sympathetic stimulation when you have an orgasm? Yes. Is there sympathetic stimulation when you're in pain? Yes. So basically any that will stimulate sympathetic response, okay, will trigger autonomic dysreflexia, which again, these patients are high risk for because they have no sensation or movement below the level of injury. Okay. So those are your triggers. So look for it. You'll be lucky if it's the bladder. Not so lucky if it's the rectum, because you know what you'll have to do. So the bladder, good thing the bladder, which in my patient's case was the problem. Okay, so I was lucky. If not, we'll have to do this. The second one, which is the rectal disinfection. Yeah. And then check the skin. Okay, so check for all triggers. Okay, all possible triggers. Here, something again, draft of cold air that can also stimulate sympathetic response. And the rest would be symptomatic treatment. So of course, we have to lower the blood pressure, yeah? My patient's blood pressure was in the 225 something and over 115, around that area. So we need to give, but usually the elimination of the trigger, let's say here you rapidly empty the bladder, or you relieve pain, or you relieve the fecal impaction, that usually is enough to drop the blood pressure. But if it does not, then you'll have to give an antihypertensive. So labetalol or normodine or hydroxyzine, for instance, any vasodilator, okay, intravenous will be given. And if this patient survived, of course, you have to tell them what happened, because are they at risk for more? Yes, once they develop one, it will happen again and again and again. So you need to tell the patient what just happened, right? And then tell them that this may happen again. So after they survive this, they, of course, they'll be put on what do you think will be included in the plan of care forever? A bowel and bladder regimen. Okay, meaning the patient must be taught to palpate the bladder. Okay, see, is your bladder empty or getting full? Okay, and then always jot down, when was your last bowel movement? Okay, or let's say check your skin. Okay, make sure there is nothing broken, or check where you're sitting. Okay, make sure your balls are not, you're not sitting on your balls. No, because that's not fast acting. So we use IV, hydroxyzine, usually labetalol, or any calcium channel blocker. But all of them will be IV. Like I said, we'll discuss PE another time. One more thing here about, okay, here. For childbearing age, both male and female, educate the patient and then reassure them that, yes, they can still enjoy sex. In fact, they can still get pregnant. Okay. Just tell them though to watch for autonomic dysreflexia, meaning they have to empty the bladder before sexual activity. Yeah. Yes, they can still have erection. Patients can, although it's not the same as normal anymore, meaning uh, all of us here, it starts in the mind, right? We just think about it and there's stimulation. For these patients, they may have to work extra hard on their erection because, I mean, it's not going to be on command. Okay, so they'll have to work harder at it. But they will achieve full erection. Okay, and however, the ejaculation is all reflex now. It's not, it's not all um, psychological anymore. Yeah, because there's none. Okay, it's all reflex, so it's unpredictable, and they never know if it's sperm or if it's urine coming out. Okay, because either one, again, it's all reflex now. But don't worry, as long as there's no UTI, I mean, urine is sterile, right? Yeah, so it's fine. But it'll be, of course, it'll be messy, but
What?
yeah, because you can urinate, they can urinate, during sex. Again, all of this will be all reflex now. It's not the same as normal sexual activity. Ejaculation, orgasms are all reflex. That's about it. Any questions on spinal cord injury?